Well, hello and welcome to the 27 Degree with Chris and Nancy. And today we'll be discussing podiatry with Dr. Tiffany Hodgson. So before we begin our conversation, I'd like to thank our sponsor, Bay Coast Bank. Bay Coast Bank is just right for all of your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more. As always, you can support the 27 Degree with Chris and Nancy by subscribing to us on YouTube or your favorite podcast platform, and by following us on Facebook and Instagram. Also, please remember to leave a review. And of course, 5-star reviews are greatly appreciated. Can you tell us a little bit about yourself and about podiatry in general?
Yeah, thank you for the invitation to come today.
Oh, we're really excited to have you here.
Very excited.
This is something we've been wanting to do for a while.
Yeah, so I'm a podiatrist. I practice at Primacare here in Fall River, and I've been here since 2017. I started practice in 2004. And I was in private practice in another suburb. So, I'm from Minnesota originally and came out here to do my residency training and ended up staying.
That happens a lot, it seems. Yeah.
Yep.
Where did you do your residency?
I did it at Roger Williams Medical Center in Providence.
Okay, great. Mm-hmm. That's excellent. Good. So tell our audience a little bit about what podiatrists do. We'll just start with that.
Yeah, sure.
Really with the basics.
So podiatrists are specialists of the foot and ankle. We have specialized training when we go into podiatric medical school. So we already know that we're going in to deal with feet from the get-go. We do kind of general courses. So we do from the head to the feet. Everything's included. And I would say podiatrists these days is a little bit different than maybe the people who are just past retirement or are in the retirement vein. I think most podiatrists coming out of training are all surgically trained at this point. Whether or not they choose to do surgery, is one thing, but pretty much everyone has surgical training in the foot and ankle.
That's great.
What interests you about feet? Like, why did you want to go into feet?
Mm-hmm. I was blessed with bunions at a very early age. So I can remember being in my early teens and having a bunion that was, I always say it's like the grandma bunion that's kind of flapping in the wind, one of those. Yeah. So I had a great podiatrist, and I was at the point in my high school career, I was in athletics, and I got to the point where I was really uncomfortable playing sports, putting my cleats on, my ski boots, my sneakers without having pain. So went to a podiatrist, and for me, it was a big change in my quality of life. And then when I decided I want to go into medicine, I thought, well, specialize in something, and
it's a cool little
here
story.
I am.
That's great. It's a great story. I mean, that often happens, right? Someone has a personal experience. That's a great story. Tell the audience, if you could, a little bit about the education that podiatrists go through. How many years is it? And, how does it compare to, say, medical school or whatnot?
Yep. So everyone has gone through their undergraduate degree training, their 4 years of undergraduate school. And when you graduate there, you essentially go into a college of podiatric medicine. And there's a bunch around the country. They're all private institutions, unfortunately. And then that's another 4 years of just training and education, primarily focused on the lower extremity. But as I mentioned, we do gross anatomy, head to toe, and pretty much everything else. A lot of the colleges now are actually, the courses are all integrated with MDDO students, so they're all together doing the same thing. And that kind of happened, I would say, in the early 2000s, where they started making that change.
So that's interesting. So are there folks who go to medical school and then become podiatrists, or it's really separate?
It's typically separate. I do know of a few physicians who have an MD, DPM, even a JD along with that, but that's just a lot of education.
But there's a lot of sharing and training.
Yeah, definitely. And then once you're done with your 4 years of podiatric medical school, you go on to do your residency training, which is typically anywhere from 2 to 4 years, maybe even a little bit longer if you're doing a fellowship. So
pretty similar to what we go through for our medical training.
Right.
Really the same amount of time in that. That's interesting. So you started talking about bunions. So why don't we just get into that and tell us about what a bunion is and how you deal with it.
Yeah. So a bunion is a deformity in the foot, and it's near the great toe joint. So some people will come in and say, I have this big bump in the ball of my foot. My foot looks like my Aunt Sally's. And so it's really a hereditary deformity. It typically is progressive. It gets worse as age most often.
Are you born with them?
Most likely, no. I mean, you could see some juvenile patients and
Yeah.
pediatric patients who have bunions, but they also may have some underlying
Right.
conditions, maybe some rheumatoid arthritis, juvenile rheumatoid arthritis with it. Treatment, there's a ton of treatments that we can do for it. And typically, I always recommend to start with the conservative things because
Sure.
that's the easiest and the
Right.
safest. And that's anything from, primarily changing shoes. Shoes play a huge role, and happy to branch into that later. Shoe changes, ice, anti-inflammatories, padding. Sometimes cortisone injections can be helpful if there's a joint pain or if there's a bursa present. And then, maybe some inserts or orthotics. And then I think when all else fails, surgery is the answer.
So those little pointy shoes that are high heel that women shove their feet into at a really bad angle, does that cause a bunion?
I don't think that it necessarily causes it, but I think it can certainly play a role in the advancement of it, right? Because
Okay.
there's a lot of pressure in the forefoot area and toes are kind of squished together. And if we add a heel to it, it's more
Right.
pressure on the ball of the foot.
Yeah, that can't be good for your feet.
No. But, some people are just, they are into fashion
Yeah,
and
yeah.
no matter what, it doesn't matter.
Right.
Mhm.
Understood.
I might want to jump to shoes now.
Sure.
So high heels,
Yeah.
that causes some problems. But what about like the opposite end of that, like flip-flops?
Yeah. I always tell patients flip-flops bring us a lot of business. There's certain types of shoes, and those are generally the very flat shoes, the flexible shoes that just don't lead to support to the feet. Or if we look at flip-flops, sometimes people will be more prone to ankle sprains. But yeah, I think, shoes do play a huge role in how our feet feel. And I think a lot of times patients aren't educated enough on what they should be looking for shoes. So I kind of go into this big thing of, this is what you're looking for and pick up the shoe and, give it a good feel.
So what are we looking for in
Yeah,
shoes
so
to keep our feet healthy?
Yep. So you want to find something that has decent support. So I always recommend kind of picking up the shoe, pressing from heel to toe. The shoe should give slightly, just a little bit in the ball of the foot area in the toe box. But if you pick up a shoe and you can kind of bend it in half and put it in your
Yeah.
pocket, don't want to be wearing those. So that there's a lot of shoes out there now that have these kind of minimalist aspects to it. They're very light,
Right.
very flexible.
Like my Allbirds, I love those.
Yeah,
They're really bad for your feet, I bet.
Well, and it's
There's no
one thing
support.
if someone doesn't have any foot problems or
Yeah.
foot deformities, then I'm not really too concerned to say you need to change to this.
Right.
But when people are coming in and they've had pain in their feet for months or years, then we got to take a serious look at that. So shoes that are very flexible and you can kind of twist them and wring them out like a rag, not good either. I do have some issues with memory foam.
Yeah, I was going to ask you about that. People think that's great and maybe not so much.
Yeah, conceptually, I can see why it seems like a good idea because,
Right.
especially when we have pain in our feet, it's soft, it's squishy, it's going to feel like I'm walking on pillows all
Yeah.
day. But again, there's not anything to support the foot to take strain off of the ligaments, the tendons, the muscles. So it's just very fatiguing.
So what about like like a Birkenstock like shoe? Like if you want it because it's summer. Like,
Yeah.
I'm not going to wear big orthopedic shoes in the
Sure,
summer or
yeah.
something. Like you want to wear
Yep,
something.
and I think shoes like Birkenstock that have a nice cork sole, have a good footbed in them and support. I'm good with those. But flip flops, we had those kind of like jelly shoes for a little
Yeah.
while.
Oh, yeah, right.
Well, now you have the
And-
Crocs.
The Crocs,
Crocs.
yeah. The foam is kind of tough, and I don't find that those give great support for the feet. So I can see that they're great. They're quick to throw on.
Yeah.
People like to wear them around. They have all these colors
Right.
and little gems to put in them.
Yep.
But they don't typically give great support. I would say Crocs I would maybe consider for a patient who has a lot of swelling and tends to really expand during the day. They're kind of
Yeah,
loose fitting. They might do okay with those. Yeah.
Can you lose your arch if you're wearing shoes that don't have good support? Can you become flat-footed?
I don't think so.
No? Okay.
Yeah. I mean, arches can certainly drop. I generally would see that maybe in a different patient population. And that might be someone who has like a tendon dysfunction, or
Okay.
maybe they have collapse of their foot from Charcot deformity from having diabetes and neuropathy. Yeah. But most often, our feet do change as we age. And I tell people, make sure you get your feet measured once a year because, our bones as adults are done growing, but they do change a little bit. They get a little bit wider and a little longer, it
How
seems.
about with pregnancy? Do women lose their, some of their, I don't know, Do their arches change and their feet change? with
Sure. I
pregnancy?
mean, that nice relaxing hormone that helps us deliver babies
Mhm.
can also affect the ligaments in the feet. But I think overall, it's more to do with swelling and just
Yeah.
foot fatigue. So, maybe making sure that during the pregnancy, if they're having a lot of foot swelling, maybe getting a shoe that's a half size or a size larger to accommodate for the swelling during the day.
Okay.
Yeah.
So getting back to the bunion, because we started with
Yeah.
that. When you surgically deal with it, what are you actually seeing in it? What is a bunion
Yeah.
specifically?
The bone, so the metatarsal, those are the long bones like we have in our hands, metacarpals, the long bones there. They start to kind of deviate and shift. So the one that's closest to the big toe, if we think of this as, the
Mhm.
bunion area, it kind of deviates outward, and then the big toe starts to kind of deviate towards
Yep.
the second toe.
Mm.
What we see when we look in the joint surgically is sometimes there's adaptations to the joint where there's been just kind of wear and tear over time, and the cartilage starts to become eroded or lost on one side. So we can see that, or we can even see where we get spurs associated with it.
So the bump that you're seeing, is it
Mhm.
actually bony growth, or is it just that the joint is actually now malaligned in a way?
Both.
Both. Okay.
Yes. Yep. So there's sometimes a little bit of hypertrophy or overgrowth of that
Mhm.
bone on the side, which seems to, people say it seems like it's just so much bigger, and you can kind of feel it. But there's a little bit of that, and then there's that adaptation of the joint where the big toe is now leaning towards the second toe.
So when you fix it and you
Mhm.
align it and do what you need to do surgically, do you still have function of that joint? Because that's an
Yes.
important joint.
Yeah, we would. The ideal thing when we do surgery, especially near joints, is we really want to maintain function or if it's not there, restore function.
Okay.
So yeah, we can typically kind of realign things that. Most bunion surgeries require cutting the bone and repositioning it,
Mhm.
and then using some type of hardware there to hold it in place while it's healing. And usually the hardware stays in indefinitely. Yeah.
If you have a bunion on one side,
Mhm.
are you going to be prone to having it on the other side too?
Not
Matching bunions?
Yeah, not necessarily. Most people have
Actually,
most people have two different feet, asymmetric feet.
mm.
For myself, I had a bunion on one foot, and I have a little bit of a structural
Okay.
hallux limitus on the other
Oh.
foot, which is just a different joint, a more
Yeah.
like arthritic joint. But some people have kind of mirror image feet, but I would say more people have it on just one side, or one side. If they do have it on both sides, one side seems to be the problematic foot.
I'm glad you said that. So, like, it's not unusual to be like a half size different in feet too, right?
Most of us, if we measure our feet, are half size different in shoe size. So obviously you're buying for the larger foot.
Yeah.
It's interesting. I get a lot of patients who come in and they're concerned that they're not symmetrical. Like something is a little different.
Mhm.
Like I have this here and it's not exactly like it is there. And we're
Yeah.
very asymmetrical, really.
Right. We are.
Interesting.
I mean, even if we look at our faces,
Yeah,
right?
Right.
The plastic
true.
surgeons will tell us that
Yeah.
one side of the face is not the same as the
No,
other.
Yeah.
It is true. It is
Mhm.
true.
Let's move on to warts.
Yeah, warts.
Ugh.
hmm So warts are a virus that we pick up, and when we see them on the feet, most of us pick them up
Yeah.
from walking around barefoot,
Mm.
or sometimes I rarely see adults who come in with warts. Occasionally, but they say, "Oh, I'm not doing anything. I'm just in my house." Well, oftentimes it's the children or
Yeah.
their friends who are bringing them into the house, and we might be
Oh.
walking around barefoot in our house and picking them up.
Oh.
Yep.
I really like walking around barefoot, but I have a feeling like after this podcast, I'm probably not going to walk around barefoot anymore.
Yeah.
And these are the plantar warts, which is what
Yeah.
we're talking about. These things are really, really deeply seated, right? They're hard. You can't just put some of that over the counter stuff on that you get and
and
take
it's-
care of it most of the time.
You're right. I mean, I think if you caught it early, you might have some luck with an over-the-counter
Mhm.
wart remover. Warts reside in the first 5 layers of the skin, the epidermis, and so overall, they're not super deep. Although when you're standing on them, they feel like they're
feel
hitting
like
the
it.
bone. Yeah,
Yeah.
they feel real deep. They tend to multiply. They tend to be transferable, transmissible, and so that might mean it's going from one foot to the other.
Okay.
To each other too.
Yeah, from one person to another person. Yeah.
Mm.
So, I encourage patients who have warts,
Sleep
keep your-
alone.
keep your feet covered. So that could be, with a Band-Aid, a sock, a shoe,
Okay.
making sure that we're cleaning the showers or bathtubs with some type of a cleaner that will help to destroy wart virus.
So again, this is very important for everyone going to the gym and everything. You want to make sure you have something on your feet when you're showering and all that
Definitely.
stuff.
And even on the pool decks, it's if you're out swimming in a communal area, make sure you're wearing some type of shoe sandal up to the edge of the pool. If you decide if they're not water shoes and you want to take them off, fine. Just take them off at the edge of the pool. And then, most pools are chlorine based, so that should be help to destroy wart virus that might be lingering around, and thoroughly washing your feet after you get out. My children who are participating in swim lessons and stuff who come into the office, I think, sometimes they're being shuttled from one activity to the next. And they don't really have time to shower. Sometimes even just a simple wiping the feet down with some hand sanitizer or something just until you can get home and wash them thoroughly.
Idea.
Yeah,
That's a good idea. Yeah. Human papillomavirus, it causes so much so many problems. It's amazing.
Tough to get rid of.
From head to toe, really, right?
Yep.
We see a lot of people now who are coming in with throat cancer from HPV.
Oh, wow.
It's actually more treatable than some of the other, in most instances, in some of the non-HPV associated throat cancers. But then there's cervical cancer too. It really it can cause so many problems
Everywhere.
It's really remarkable. Yeah.
So now, when you discover a wart on your toe, like after you freak out, what are you doing? Like, are you looking like over-the-counter stuff first? Like, what's the first line of defense?
I think that's very reasonable, as I would look for an over-the-counter wart remover. I always prefer the ones that you paint on the skin instead of the medicated Band-Aids, because especially dealing with the feet are sweaty.
Yeah.
There's a lot of shear forces when we walk around. So someone might put a medicated pad here, and by the end of the day, it's moved away.
In a different spot.
Yeah.
Right.
But I think that's a really reasonable first step. And I think trying to treat it at home with an over-the-counter wart remover first is fine to do. And then if it doesn't seem to go away, I think within a month or so, then probably need something stronger.
So that's when we're calling you up and be like, help.
So fungal nails. That's another big one.
Talk about that.
I get patients all the time asking about that.
Yeah.
Are they ever curable?
I think they're definitely treatable. I've had some patients who certainly have been cured, but the incidence of recurrence is pretty high within the first 3 years after treatment. So I think part of that treatment is educating patients of good foot health hygiene, how to take care of the feet and hopefully prevent fungal.
So how do you prevent it in the first place?
So I would say most people tend to get fungal nails sometimes by trauma, sometimes by having pedicures, sometimes from an athlete's foot infection. I would say the majority are probably athlete's foot infections that start to invade the skin around the nail and it kind of creeps in, and there we now have fungal nails. The same is true vice versa. Someone has fungal nails and they might not have an athlete's foot infection, but if they're not treating the nails, oftentimes they'll get an athlete's foot infection. Yep.
But there must be like something inherent to one's immune system, though, that is an issue, because you see people who they have chronic athlete's feet, chronic onychomycosis, which is a toenail infection we're all talking about. And then others have none, right? So why is that?
There is a little bit of, they've done studies, there is a little bit of a genetic predisposition to being susceptible to these fungal infections. And we certainly see it. I know you see it with patients that, there's a partnership. They've been together 50 years. One has athlete's foot and fungal nails, and the other one doesn't, and they never cross-contaminate each other.
Yeah, so there must be something.
There definitely is a genetic
or whatnot there.
Yep.
So now, when you have a fungal nail, it's discolored, it's thick, and it can spread to your other nails.
Yes.
So you can't just pull the nail and it will go away, right?
Correct. And that's because the infection is not just in the nail, it's actually in the skin underneath the nail, in the nail bed and where the nail grows from. So to treat it, and a lot of patients will come in and say, I've had this fungal nail for all these years, I just want you to remove it. Well, if we just remove it and we don't do anything, it's going to grow back in the same manner. My feeling is if it's something we're going to treat, let's test it first, because there are times where nails may look very fungal, and I tell patients I'd lay $100 down and say this is fungus if I've ever seen it, and sometimes I'm wrong. So it is good to get a good diagnosis, and we do that just with very simply trimming and taking a nail sample and maybe a little bit of the debris underneath the nail or on the nail bed, and send that to the lab and get a good diagnosis of, is this fungus? Is this a yeast, mold, or bacteria? And sometimes it's kind of a mixed infection.
Okay.
Yep.
So then if it is a true like fungal nail, what's the treatment for that?
Yeah,
that works.
So there's both topical and oral antifungals and pills.
Yeah.
So topical treatments are less effective, and that's because it needs to penetrate through the nail to get into the skin, right, to treat the infection.
Right.
Topical preparations are typically used for a year or more, and they're not overly successful.
Yeah, I haven't had any real good success with it. I
Yeah.
just find people get sick of it after a while and they stop using it.
Right. And I try to explain to patients that if they're going to go really any treatment route, you're not going to see an improvement right away. Even with the topical, I find, unless you have a very superficial, a very light case that sits on top of the nail, you're probably not going to see any improvement for 6 months. So to kind of prep them with that knowledge so that they aren't getting frustrated and say, I've used this for 2 weeks and it's not changing.
Right.
We have to first kill the fungal infection and then let the diseased nail grow out and then the healthy one grow in. So pills that work better, not everyone's a candidate for pills, although overall I would say there's very few side effects and limitations with them. But even with that, I tell patients that it's not going to be an overnight change. It's probably going to be from when you finish the medication a couple of months after that you start to see the new nail growing. Yep.
There's a lot of home remedies that people try for this stuff too, which I'm interested on your take.
Me too.
I know for warts, people say I put duct tape on the wart.
Like white vinegar and apple
vinegar
cider vinegar.
on my nails.
Yes,
Yeah.
yeah.
Have you seen any of that actually work?
I have not. And they've done studies, in the literature about these home remedies, Vicks Vapor Rub, Listerine,
that's another
vinegar.
Yes.
You hear all these different things. So I think, if we're talking about warts, the theory behind it is that for duct tape, you're going to put it on there. You're going to kind of macerate the tissue, which means that the tissue is going to get really wet and kind of soft, like you've been in the water for too long. And then you pull the duct tape off and it's supposed to pull some of the wart off with it. So that's the theory behind that. With the topicals, Listerine and Vicks Vapor Rub, I just don't see any of that work, and I'm not really sure where the thought process is behind it. I saw a really extensive case of essentially like a contact irritant dermatitis on a patient who had used an organic oregano oil on her nails, and she had such a secondary inflammation on all of her the skin around the nails. It was really significant. But sometimes when we use these other things, or we Lysol our shoes and we put our feet in our shoes, I don't advocate that without socks, but you can get that contact irritant dermatitis from a chemical.
And I was just going to say, and I think on the other side of the spectrum, the oral meds I found are very well tolerated. I mean, we have to, we worry about if someone has liver dysfunction or liver issues, and you check liver enzymes. But I've only seen a couple of patients have an issue with those meds over the years.
Right. I would say for the vast majority of people, it's very well tolerated. There's very few drug-to-drug interactions. A couple of, I would say maybe a rash, stomach upset. Those are kind of the typical things. And for most people, it's, okay, my stomach's a little upset and I feel like I can muster through it for a couple of months because I'm tired of these toenails. But some people can't. Some people, I've seen a couple of full body rashes, then we stop the medication and try and go for a topical.
Sure. Makes sense.
So I had a very important question.
Go ahead.
Pedicures. If you have a fungal nail, is that it? You can never get a pedicure again? Because say this fungal nail, you've had it. It's been like your friend for 4 years.
Yeah. So I think for people who enjoy pedicures, I am not one of those people. I don't find that to be a relaxing activity. But for people who enjoy it, I tell them, pick a reputable salon, pick a salon that sterilizes their instruments. And I show them, in the exam room, they should come in a peel pack like this. It's what we use in our operating room. It's the highest level of clean. Or if it's someone who goes frequently, bring your own instruments. I also encourage people to bring their own nail polish because I think the theory is, if they're using
that makes sense.
polish on someone who has fungus and now they're using on you, chances are you may pick it up. That bottle's contaminated.
Makes sense.
It's ask them to cut their nails straight across. A lot of times with pedicures, they find trimming the nail back or rounding the corners. They'll start doing that. And sometimes that leads to infections of the skin around the nail or ingrown toenails. And then I think most importantly, make sure you're removing the nail polish. I would say weekly. It's kind of a big pill to swallow, especially when you're spending a lot of money to have someone do the service for you. But, my concern is when we leave nail polish on for a long time, is a great way to have another fungal infection. So in your question of if you have a fungal nail, can you ever have a pedicure? I think you can. I certainly advise my patients after we're done treating their nail fungus, if you're going to have a pedicure, these are the things you need to follow. I know some places, if you do have fungal nails, won't have you there for they'll just say you need to go see a doctor, and
it's understandable.
Yeah, right.
Yeah,
figure it out. So what about, like, a lot of people just don't get a regular manicure or pedicure. They're getting like the gel nails or the acrylics or the dips. Can you comment on that, and then we'll move on?
Are they getting those?
I wanted to answer all my nail questions.
Are they getting those on their toenails? That's more hand, right?
But no, because you do it on your toes too. Yeah,
yeah, and it's interesting. There are people who even do like acrylic nail toenails. They may have
definitely gel because you're in the water all the time and it stays on for 2 weeks.
Wow. I find that they're just a little too harsh for the nails. To get them off, you really have to file it all off.
Yeah,
to get to try to get it off with polish, and even if it's a gel polish remover, it still is difficult at best.
Right.
But you can sometimes see when patients will come in, they'll have these kind of white little marks on their nails, which is some damage to the nail. Sometimes it could be fungus, a superficial type of fungus that's on the nail. But it's hard. I understand the purpose of it and wanting to preserve the pedicure for a while, but I do have some patients who have a damaged nail that they may have an acrylic nail put on just for cosmesis. And, maybe they're going on vacation and they don't want someone to look at their odd toenail. So they'll do that.
All right. So you had mentioned ingrown toenails. Can we talk about that a little bit?
Yeah.
What causes it?
So different causes, often caused by improperly trimming the nails. So that might mean trimming the nail up the side or kind of digging after it. I have a sect of my pediatric patients. It's usually my young men, maybe 11 to 14, who are tearing their toenails off and ripping them off. That tend to lead to a lot of issues with ingrown toenails and infections. Yeah. Hereditary also. The shape of our nails is hereditary. So some of us just have more curved toenails than flat, and that will maybe predispose us to issues with ingrown toenails. And, sometimes we might wear a shoe that's a little snug. We may never have issues with ingrown toenails, but gosh, we wore these great pair of shoes to a wedding and danced all night, and we might end up with a problem with the nail.
So should we be cutting the nail like straight across and not trying to give it that nice little curve on the end?
So different types of nail trimmers. There are nail trimmers that have that little handle that we turn around to open and close, and we kind of use it this way in our hand. They either come with a straight edge or a kind of curved half moon edge. So straight edge is fine for toenails. I would say the majority of people pick up that kind of curved half moon edge, and that's really not meant for toenails because as you get to the edge of the toenail, it's hard to cut it straight with that. You kind of end up creeping up the side of it. So straight edge for those. And then there's another type of nail trimmer called a nail nipper. It's typically what we use in our treatment rooms. And some people say, oh, it looks like a plier. It's kind of scary. But they typically have a nice straight edge, which makes trimming the nails very easy.
Primacare is Southeastern New England's trusted leader in medical care. With offices in Fall River and surrounding communities, we're dedicated to your well-being. Our carefully selected team of more than 150 providers offers world-class primary and specialty medical care. Primacare doctors are supported by a skilled staff trained to deliver comprehensive radiology, imaging, and testing services. Primacare is large enough to take care of all your medical needs, but small enough to care for you personally. Primacare is by your side.
So athlete's foot, kind of the same type of discussion that was earlier, right? We have to watch, like, especially if we're in the gym, like have our feet covered in the showers. Any other tips for avoiding athlete's foot?
I think just thoroughly washing and drying the feet. So I gave a lecture years ago, and I didn't realize until after how many people had questions about foot hygiene. So the general consensus that I got and that I still get from a lot of my patients is that, well, when I'm in the shower, the soap's running down my body and my feet are getting washed. No, you got to lather up, soap and water in between the toes. And then when you get out of the shower, dry the feet, tops, bottoms, in between the toes. And I think for people who have issues with athlete's foot, certainly, I always encourage them to use a separate towel for the feet so they're not spreading it elsewhere.
Yeah, that's a good idea.
What about use of powder and stuff? Like you see a lot of powders that are, use this for athletes,
Yeah.
or like,
I don't love powders.
okay.
I feel that powders, their action is to absorb moisture, but if
Yeah.
you're putting it right on the skin, it seems like it just holds it right there.
Oh.
I would rather see someone put powder in their shoe, put their sock on, and then put the foot in the shoe to help kind of pull the moisture through their
That makes
sock
sense.
into the shoe. Technology in socks has changed a lot over the years, which has helped to keep the feet drier and also therefore less issues with athlete's foot, viral bacterial infections.
I do so many things wrong. I don't wear socks. I walk around barefoot. It's terrible.
You're going to change your whole life after.
Habits
I
can
know.
change.
Yeah, you can change these
I
habits. It's not too
guess.
late.
I guess. I'm going to move on.
Yeah. All right, let's see what other conditions you have. So we know now you have fungal nails. athlete's foot.
God. Let's move on to what I had last year, plantar fasciitis.
Oh, that's a good one. I see so
Yeah.
much of that. It's so
Right.
prominent.
It really is. So plantar fasciitis is inflammation of a ligament on the bottom of the foot called the plantar fascia. And it starts at the heel and actually extends all the way on the bottom of the foot up to the toes. And it's not a, very stretchy ligament. It's pretty dense and fibrous, and it gives our foot some structural support. So it typically occurs as an overuse injury. People have been
Oh.
on their feet more,
I was
new
just gonna
job,
ask
new
you that.
exercise program. It can happen from wearing shoes that aren't supporting the feet. It typically, I would say the majority of people who have plantar fasciitis have very tight muscles in the back of their legs, so their hamstrings, the calf muscles, and these are all interrelated. So a very common problem, something that I think every podiatrist deals with every day and probably multiple times a day.
Yeah.
Is there like a certain sneaker that you really like, or like you'll recommend for people that are having a little problem with this?
Yeah. Sneakers in general, I would say, kind of pick them up and give that test. I have examples of shoes in my office that I pick up and show patients, and I'll pick up their shoes and kind of see where they lie. But, I generally recommend running sneakers for people, even if they're not runners, even if they're just a regular walker, or they wear sneakers for their, after work or at weekend activities. And I like running sneakers because they generally have better cushion in the heel and in the ball of the foot, which most of us need, especially as we get older. We start to lose some joint mobility, and it helps for that cushion.
You're older than me. What are you talking about?
So how do you and it's painful,
Yeah. So some people who have plantar fasciitis may have pain just in the heel, on the bottom of the heel. Some people have it just in the arch. Some people have it in both places. And occasionally I see it move from one place, like, oh, my heel pain's gone, but I have this horrible arch pain. Occasionally I may see it up towards the ball of the foot where the ligament continues to extend, but that's pretty rare.
how long is it going to last? So someone is probably waiting, thinking, oh, this is going to go away. It's going to go away. It doesn't go away. They're calling you. They see you. Then what are the next steps that you do?
Yeah. Unfortunately, a lot of people wait, I think, too long. They might be waiting 6 months or longer.
Because we all think it's going to go away.
Right. I think I'm guilty of that too. We think, oh, I can kind of treat this myself and it's not too bad. But the longer that things linger on, the tougher they are to treat. They go from an acute problem to a chronic problem, and it just gets tougher. But
Yeah, so I see a lot of people who they've already tried a lot of the things probably that they need to try. So they're wearing shoes that have good support with a good cushion in the heel. Maybe they've had the gel heel inserts they've put in there. They're icing it. They're stretching. They still have pain. What happens after that?
yeah,
If they come to see you, what do you do?
Right. So I generally will recommend an x-ray to take a look at the foot structure and to make sure that there isn't any other problem that might be mimicking the same symptoms.
Makes sense.
Bone tumors in heels, uncommon. It's not something I don't want to upset people, but it's not a common thing, but certainly could happen, could lead to heel pain. So the treatment really is, I may kind of refine their conservative stuff that they've been doing. And, for instance, I had a gentleman today said, oh, I've been stretching. I've just been pulling my toes back. Well, the simple act of pulling the toes back is not enough to stretch the whole backside of the leg, the hamstrings and the calf. So I might refine their stretching program a little bit, icing, sometimes anti-inflammatories, cortisone injections, night splints, physical therapy, insoles. And you mentioned about the gel heel cup. I generally don't find that those are overly helpful for this problem. It seems certainly I think intuitive that we have pain here, we should cushion it. But typically someone would benefit more from a more supportive insert or orthotic, which is to better balance the foot and take some strain off of it. So
now, like, once you have it, are you always kind of prone to it?
I think people can have it and get rid of it. I think that those of us who have tight muscles in the back of the leg are probably going to have some likelihood of recurrence at some point. And I encourage my patients, once we're kind of in that point of, you're doing great, we're going to discharge you, to do kind of a routine stretching exercises. So it's definitely cut back from what I give them to do when we're actively treating it. But I think just stretching once a day, certainly as our in America, we are not people who stretch, right? No. We would have less health issues if we stretched on a regular basis. Yeah.
Why is it with plantar fasciitis that when patients first get up in the morning, the first few steps are the worst, and then it kind of gets a little better as they're walking for a while? Is that just stretching out of the ligament?
Yeah. So that's a symptom called post-static dyskinesia, which fancy term for pain with weight bearing after a period of rest. So a lot of patients will say, I've been sleeping for 8 hours and I get out of bed. Why is my foot hurting? Well, if we think about this ligament, that is, if we think about our foot, and we can all kind of look at our feet when we're sitting on the couch, how it's relaxed and it seems like we have a little bit more of an arch. Well, things are kind of tightening up. Our muscles are tightening up. And then we go to stand up on it. It's this abrupt stretch. And it starts this inflammatory cycle, which oftentimes has maybe some little microscopic tears along with it. So that's, and it does get better typically after you've been up moving around for a few minutes until you sit down again. And then when you go, sit down and drive someplace or sit down and have a meal or watch a movie, then you go to get up again and there it is back.
Yeah, that was tough. And like you said, there's some things that worked and some things that just didn't. But we'll have to keep in our minds that we need to see you earlier rather than later.
And I think that there's a ton of conservative things to do for plantar fasciitis. Rarely do, at least in my patient population, rarely do I need to do surgical treatment to resect a piece of the fascia as far as treatment. I mean,
we know what happens too. It's like, oh, my foot hurts. You're not thinking, oh, this must be plantar fasciitis.
But most people, once they've had it, never forget it. And then they'll tell, and then they'll tell their friends and their family members, like, oh, you have heel pain. Well, you probably have plantar. I mean, my husband can diagnose plantar fasciitis at this point, and he's in sales.
Yeah, there you go.
Oh my gosh. So, out of the patients that you see, what are some of the really common things that you'll treat?
Yeah, so common, like we talked about, a lot of the skin conditions, ingrown toenails, certainly a lot of, tendon pathology just from overuse. People being on their feet too much, or the weekend warriors who maybe they're not super active, but they went out and walked the Freedom Trail for the weekend. Right. Certainly the foot deformities, the bunions and the hammer toes, see a few neuromas here and there. I find that the neuromas, which are the pinch nerves that we can get in our feet, sometimes come out of the woodwork. I might not see them for a while, and then all of a sudden I have 3 people on the same day who show up with them.
So what is a neuroma?
A neuroma is a pinch nerve in the foot, and typically—
And how do you get that?
Yeah. Women have it more frequently than men, and it's really based on shoe styles, shoe fit. So typically a more slim cut shoe, a tight shoe, ill-fitting shoe will tend to lead to that problem. Wearing heels can lead to it. Patients will describe kind of a bunched up sock feeling on the bottom of their foot, or that, it feels like I have a lump in the bottom of my foot. Sometimes they'll experience sharp shooting pains to the toes or numbness of the toes, and that's because the nerve gets pinched between the bones and starts to swell and causes these symptoms.
Are there, with the high heels, are there like the wedge heels versus a stiletto versus whatever? I mean, not all high heels are wicked bad, are they?
I don't think so. And I think that, even my patients who come in with bunions and say, I have, 50 pairs of heels that I can't wear. Well, I think we just got to find the right one, right? So, and I'm an example of that. I'm someone who even still has a bunion after having surgery. I still have a little bit of a bunion. But yes, I think to your point, there are certain shoes that are probably a little bit better. And I would say for someone who has maybe issues with neuromas or inflammation on the ball of the foot, or even plantar fasciitis, I would rather see them in maybe a wedge or a platform shoe versus a heel.
Okay. All right.
But I will say with plantar fasciitis, I would rather see someone in a small heel versus a flat shoe. ballet flats seem to be, again, no support for the foot. So I'd rather mechanically see them in a small heel.
And they were so trendy. And you try them on, you're like, oh, these just aren't going to do it. There's no support.
Right.
But anyways, so the hammer toes that you had mentioned, is any technology or less painful options to fix those little hammer toes?
Yeah, the technology is probably very similar as it was surgically decades ago. The changes have been probably some different implants to put in the joints or to connect the bones together after you resect a joint versus having wires sticking out of the toes. There's nothing wrong with doing it with wires, and I think a lot of my colleagues still do it that way. But it's probably about the same. You're either, if the toe is very flexible, oftentimes we can deal with it conservatively by some padding or strapping or shoe changes. But surgically, if it's really kind of soft and flexible, usually you don't have to do too much work. You're kind of going in and resecting some bone. If the joint is very rigid, and you can kind of figure that out by trying to straighten out your toe. If it doesn't budge, it's a rigid hammer toe, and that usually needs to have the bone resected from on either side of the joint, and then the toe fused, that joint fused.
Is it usually one toe, or do people usually have multiple hammer toes?
They usually have multiple. Yeah.
So are you doing, say they have it on the right and the left foot, are you doing all the toes on the right foot, or you do one at a time? What's that call?
I typically recommend if it bothers you. So if it's something that's symptomatic and bothering you, then yes, let's address it. But there are some people who have 10 hammer toes. Even their big toes are kind of bent like this. And for some people, they say, you know what, it's my third left toe that bothers me. Okay, well, let's address that. The downside is you kind of straighten out one, well, then maybe you have a little bit increased pressure of the other. Yeah. So it really depends, I think, on the activity level, how severe their deformity is. If it seems like it's really rigid, maybe we're fixing some of them on one side. As far as do you do them both feet together, I would say most of my colleagues probably do one foot at a time. And it's just really for, having a good foot to stand on, or if people are caregivers, it's tough for them to be,
of course,
out of commission for a while.
So we talked about the most common non-surgical issues that you see, but what are the most common surgeries you do? I
would say that's like the bunions, the hammer toes, neuromas occasionally. I generally find those tend to do pretty well conservatively, but I would say bunions, hammer toes.
How about wounds, like diabetic wounds and patients with vascular disease who have wounds that are non-healing? Do you deal with that?
We do, yeah. I have a few colleagues in our practice who are wound care specialists, so I may, if my patients are coming in and they have wounds, I may work to try to get their wound to heal in a short duration of time. And if they don't, then they're shipped off to the experts. And that may be a trip to the wound care center. They have a lot of great things that they can do and great resources to help wounds to heal. But wounds are very difficult, particularly in patients who have diabetes. When our blood sugar is not in good control, it's very difficult to heal things. And some diabetics may have issues with either poor circulation or neuropathy, which they might not be able to feel that a wound is there.
Doctors, at what point will a diabetic, at what point do you refer to podiatry? Is it all diabetics that should at some time in their lifetime see a podiatrist?
I think so. From my perspective, I think everyone should have a foot exam. Everyone should be educated on, what they need to do having diabetes and taking care of their feet, what they should be looking for. There are some patients who have extremely healthy feet. I don't need to see them back unless they're having a problem. But then there are people who, on the exam, we might find that they have neuropathy or poor circulation or both. And those are people who are a higher risk patient that we probably want to be seeing on a routine basis to do a foot exam. They may need some nail or callus care, which we do also.
So when you're talking about peripheral artery disease, how do you know if someone has that? What kind of tests do you do for that?
Yeah, so my first test that I do is I just put my hands on their feet and I start feeling for their pulses. So we all should have pulses on the top of our feet and behind our ankle. Okay. And so that's kind of the first and foremost. If someone doesn't have it there and they may have some symptoms of poor circulation, like they're getting cramping in their legs, they have difficulty walking, they're skin is discolored, it's cold, then I'll send them to the vascular lab or the vascular specialist to say, take a look at them. And they have some non-invasive testing. So I say that because sometimes people are worried about testing of, am I going to be poked and prodded?
Right.
And it's pretty simple, the testing. It's, putting blood pressure cuffs on different segments of the legs and the arm and checking for differences in the pressure to see if there's any blockages.
So you mentioned cold feet. Is that always like going to be a red flag that you're thinking, or can people just have cold feet for other reasons?
Yeah, some people have cold feet for other reasons. Certainly with some thyroid conditions like hypothyroidism, sometimes we have a little perceived coldness or even things feel cold. There are people who have a condition called Raynaud's disease who may show up with its little microvascular spasms in the small blood vessels of the fingers and toes, and they may show up with having some cold feet. But yeah, it is concerning. I sometimes will see patients who one foot is warm and the other one's cold. Well, that is an immediate. I'm calling the vascular specialists, and hopefully they can see them within the day or two.
Very true.
Yeah.
This next question is probably kind of coming out of left field because it's a total shift from what we've been talking about. But like the wee little ones, what's the rule of thumb now for them growing up? Because, God, when I was having my little babies eons ago, it was the shoes, and then it was, sneakers were best, and then it was let them run barefoot and let them develop naturally. So what's the rule of thumb now for the little types?
I think it's really good to have no shoes on initially, right? So they can work on developing their muscle strength, and as they're starting to, get that grip strength standing and walking around. When they're really in that zone of kind of cruising around and running around, or certainly if they're going outside, shoes on all the time. Feet should be measured. Sometimes we kind of do that, hold the foot up to the shoe and kind of see. But as they're starting to get into, certainly school age and stuff, getting the feet measured and fitted properly for shoes. Sometimes it's problematic of, the hand-me-down shoes and, well, this fit Johnny at this age, and so it should fit, fit
Or
his
if
brother
you're
at the same age.
Like go into a shoe store, like if you're picking up shoes at Walmart or Target, you just kind of want to push that toe area and make sure they have a little room there.
Yeah, I think a good rule of thumb might be a little bit less for children, but certainly for adults, a good thumb's width from the end of the longest toe to the end of the shoe. With remembering that not everyone's longest toe is their big toe. Oftentimes it's the second toe.
Yeah.
So you want to make sure that there's good room because, certainly for people who are children, especially running around and playing, they might get a lot of pistoning in the shoe where their toes are hitting the front of the shoe, and that can lead to toe pain and problems.
Now, with the spring and summer coming up, any words of advice?
Ooh,
No flip-flops.
Yeah.
No flip-flops and no walking on the beach. Barefoot.
Yeah, I think, and I think that for some people who just have very healthy feet, fine. I'm not gonna chastise them for wearing flip-flops because some people, that's their shoe of choice and they do great with it. But I think ideally a sandal, if we're selecting a sandal, it would be something that has a strap across the front or top part of the foot, and then also a strap that comes behind the heel or the ankle to keep it on the foot. That's a great way to help prevent injuries and rolling the ankle, rolling the foot. I think just, examining our feet from time to time.
Yeah.
Some people have no idea what their feet look like. Right. They may come in for heel pain and they have a raging athlete's foot infection, but they don't have any idea because they're not looking at their feet. So I think just an overall look. I also would say sunscreen is super important. A lot of times people forget the tops of their feet and come in with a pretty big burn.
Yes.
Yep. So sunscreen, at least SPF 30 or higher.
So what happens if you have like really dry skin or like callous skin? Talk about that and the use of lotion and those, is it pumice stones?
Yeah.
Pumice stones. Are you in a
Yeah, I think it's good maintenance for the feet. So for anyone who's going to use a moisturizer to better hydrate their skin, tops and bottoms of the feet is fine, never in between the toes. So the only thing we can put in between the toes would be like an athlete's foot cream. That's fine. Yeah, in the towel. Yep. And then probably to be diligent about moisturizing, and if we're going to use a pumice stone or a foot file with regular use. I mean, I keep mine. I have calluses on my feet. I keep my file in my shower. Before I get out most days of the week, I try to give each foot a good maybe 20, 30-second scrub. I would try to avoid any type of metal device. Sometimes people use these little cheese grater looking things, which,
ouch.
I've seen some damage. I've seen some people who've come in who've abraded their skin and just, you got to wait for it to grow back.
Those little fish that eat the dead skin off you.
This is true. Yeah.
Are they swimming around your shower?
No, you can go for a pedicure where you put your feet in a basin and they nibble away the skin.
God, where are you going for your pedicures? No wonder you don't like to get them. Like fish eating at you. Oh, thank you.
Well, on that note.
I know, on that note, we're done. No more fish.
We've actually been talking for a long time now.
I know, this is crazy. The time goes by so fast.
There's so much you can talk about with
I call it a fish.
But do you see all ages? That was
I do.
a question
Yes.
I have. Okay.
Yep. I have some patients who are just a couple months old, and I have some who are over 100.
Wow. Do all podiatrists see all ages? Is that typical?
No. Yep. And there are a couple of podiatrists in the country who just see children. So I think that's not that common, but I would say most of us see kind of a range. Some people have preferences to deal with certain age groups or certain problems, and I tend to deal with them all because it's variety. It's just interesting. I enjoy seeing the little kids, and they're pretty funny. They have some interesting questions.
Yeah, I'm sure that must be kind of bring a lot of joy to your day, seeing the kids. They are always interesting.
Yep.
Yeah. So anyway, as we end up kind of complete the show, is there any one message or maybe a story you have that where something you did really impacted on a patient, or just maybe a message you want to get out to our listeners out there?
Yeah, I think my message would be, one, select your shoes properly. Have your feet measured once a year because our feet change. Sometimes people are surprised when we might measure them in the office and they say, I thought it was a 7 and I'm measuring an 8.5. So,
oh, wow.
It's a big change.
Yeah, it definitely is. So, so I'd say that. And I would say, listen to your body. You know yourself the best. You know yourself better than I do. Listen to yourself. If something doesn't seem right, it probably isn't. And, pain shouldn't be ignored. Right. Sure, there are things that we try to do to solve it ourselves before we go elsewhere. But, pain is problematic. We see it a lot in the feet, and there are definitely things that we can do to get it to go away. And I think, the thing that I enjoy most about podiatry that I think is great for our specialty is that oftentimes we can make people feel better leaving our office than when they came in. So that's
nice.
That's always an upside.
Yeah,
absolutely.
And any special message to diabetics?
Yeah, please examine your feet. Or if you can't do it, have someone do it for you. And don't let things go. I tell my patients, when you looking at your feet, if you see something that doesn't look right or feel right, call me. Don't wait and say I have an appointment a week later or 2 weeks later. Things can go from a very small problem to a very big problem, which could result in an amputation in a very short period of time, especially when our diabetes isn't controlled.
It's really a unique group of patients that they have to be so careful.
Yep.
It's amazing how quickly things can progress.
Absolutely.
With that population.
Absolutely. And sometimes it's as simple as, I had cold feet, and I had a patient once who put Bengay on his foot and then decided to put a heating pad on there because it was just kind of sore and cold, and he ended up with gangrene. Fortunately, the toe was able to be salvaged, but that doesn't always happen.
No.
So, but little things like that can happen.
So how do people reach you? That's another important question.
So they can call the office 508-646-7720 and schedule an appointment.
Great. Yeah, this was a great conversation. I learned a lot.
Me too.
Yeah, that's great. Yeah, it really was a lot of information. We could go on for quite a bit, but I think we got a good handle on what podiatry does, some of the more common issues that you deal with, and you had some great advice also for patients out there. So thank you. And
thanks for having me.
We're glad to. It was really great. And so I want to thank you, of course, for being on the show. And I want to also thank Ron Gamache for our intro music, the PC Institute for producing our show. If you are listening and you'd like to become a sponsor, please contact us at 774-319-4230. And Bay Coast Bank, we want to thank them, of course, as our sponsor. They are just right for all of your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more. Thanks so much, everyone, for tuning in, and we hope to see you again in a couple weeks.
Great.
Take care.
Thank you.